Thank you so much. I'm glad to be here with everybody today. So my name is Zan Nowakowski. It's a Polish last name that means of the new place. And in Western Poland, it's a very boring last name. So it's a little bit like Smith or Brown in a lot of parts of the United States. My pronouns are they, them, and theirs. And I've been in a variety of clinical education fields pretty much since the start of my life, really. I grew up at a medical school. My parents were in the developmental neuroscience field. They studied how our brains develop and grow. They were studying mice, but this had a lot of implications for the human brain, what our brains are doing when we are first developing in utero, and what that means for human cognitive health. So I had a lot of exposure growing up to medical education and also to clinical practice, not only through my own experiences as a person living with CF, but also through my parents' professions, and I didn't fall too far from the tree in what I do. I've gotten a few degrees in different socio-medical fields, so I was a lot more interested in the social context of health and illness and how we can apply that in a variety of contexts, including but certainly not limited to clinical education. So I am 40 years old, living with CF. I will give a quick visual description of myself. I am very thin, which is probably unsurprising, although that's changing. I have large green eyes with black eyeliner. My hair is kind of copper colored. It's curly, but it's up in a bun, so you can't really see that. I am wearing a black blazer with gold buttons, a pair of copper dangle earrings, and I have a bunch of other ear and facial piercings that probably are not going to show up on the camera, but I got a couple of nose rings and I think like 10 earrings that are distributed across both sides of my head. And I'm coming to you today from my home office in Lakeland, Florida. I'm affiliated with the Orlando Regional Clinical Campus of FSU College of Medicine. And I work from home a lot because my work is very task-based, and I actually do not take any in-person meetings or attend any in-person events because of infection control kinds of issues, which are probably, if we have a lot of people with CF on the call, those are probably quite familiar to a lot of you, although everyone's risk tolerance is different. All right, so what I'm going to do is I'm going to take you through kind of a landscape of renal disease in CF, thinking about issues we often face as we age, which is certainly a changing landscape for our population in the adult CF community, right? It used to be that a lot of us passed away from respiratory failure before we really had a chance to get into some of the other kinds of long-term health issues that CF can cause, but it is a progressive disease that affects our entire bodies. Any mucous membrane, any of those wet membranes in our bodies are often going to need this little protein that moves ions back and forth across the membranes of our cells, helps us move salts around. And so at the end of the day, lots of different things in our bodies can be impacted by CF as we grow older. And if we are surviving with better lung health to later ages, we are more likely to encounter some of these complications. If you were here before we started the formal session, we were talking a little bit about my own interest in this topic. Well, I'm a big believer in write what you know, and I live with renal disease as a result of my CF. I should mention that unlike a lot of people in our community in the US these days, I am not on any of the CFTR protein modulator drugs like Trikafta or Kalydeco. I am not eligible for any of those drugs. And some of the other publications that I've done beyond just the renal area in CF science and CF advocacy really speak to some of the dynamics and why that might be. I am white racially, but my background is about 50-50 lineage-wise, Indigenous American and European American. My biological father was multi-ethnic Creek, and my mother's dad was Tuscarora on one side. And both of those are, indigenous communities, although of very different size and makeup. The Tuscarora people were mostly exterminated during the Trail of Tears. The Creek Nation is very large and very diverse and is one of the 5 sovereign nations of modern day America. And then, of course, my father's family is West Slavic. They are from Western Poland. And I have a lot of acculturation from his family, but I'm not a direct genetic relative. I was donor conceived. And so my life has kind of been an exercise in being in between in a lot of ways, which is, I think I spend a lot of time in between spaces. I'm also quite open about being bisexual and gender non-binary. And those experiences of sort of liminal identities that are in between one thing and another have been very instructive to me about what matters in healthcare. So we see a lot of these disparities writ large, in who has access to what kinds of therapies, across racial groups. People who have more indigenous lineage or more Africana lineage as well are less likely to be able to take any of the highly effective modulator drugs. And this has implications for our kidney health, although it has implications in a lot of directions. And we're going to talk about some of that as we get a little bit more into what's out there in the research literature and the clinical practice landscape. So I want to take you through some of the key renal complications that we can encounter as we age with RCF. I want to take you through some prior research, and I'm going to present this in a way that really is geared toward a mixed audience, because I know we have a lot of people here who may not be in scientific fields, may not be in clinical fields, and may have very limited exposure to this literature specifically. So I'm going to try to tailor this to the fact that we have a lot of different kinds of backgrounds represented here. We're going to look at some examples of different CF kidney issues. I'll give you some examples from my own experience, but also tell you some stories at kind of a general level about things that my friends and colleagues have experienced, just in a very broad sort of way that gives you a sense of the diversity of our experiences as we age. And I will take you through some of the best practices that you can share with your own clinicians if you have CF or if you are a clinical educator teaching clinical professions learners about what matters in nephrology care for CF. And then we'll look at where this field is going, because there have been a lot of changes in the past few years. And there's really been an explosion of activity in research and clinical learning about renal disease and CF. So it's a really good time to be given this talk. I was very excited to get invited to come here and share with all of you. I'm going to try to go with the talk for probably about 50 more minutes, but I encourage you, if there's something burning that you want me to clarify during kind of the active talk portion, you can either message to everybody in the chat. I would recommend doing everyone rather than just me, so that everybody can see your question, and that will also guarantee that I see it. I've got the chat window up on my computer screen. And then we'll also have time afterwards for some Q&A that's a little bit more open. We'll try to take about 15 minutes at the end for Q&A. So please feel free, if there's something you want me to clarify, you can put something in the chat and I will read it out and give that clarification. And then you'll be able to either speak up or chat me in the Q&A after the talk. So let's get right into it here. It's going to be a little bit of a lag while I'm advancing the slides. I just provided a little bit of information about me. There's a picture of me over here on the left, in which I am in fact wearing the same jacket that I'm wearing right now. So I guess I'm that person who wore the band t-shirt to the concert. And then over on the right, I just have my basic job information. I'm an associate professor at FSU College of Medicine in the Geriatrics and Behavioral Sciences departments. My pronouns are they, them, and theirs. I gave you again the pronunciation of my name, my email address, and some social media where you can find me. I gave you my Facebook, my LinkedIn, and my ResearchGate. And I sent this information I sent my slide deck to the conference hosts, so they will be able to share it as a resource with attendees. All right, now we get into the meat of today's content. I just want to take you through some of the basic complications of CF that can appear for the kidneys. So, first of all, if you're living with CF, I'm guessing you know quite a bit already about the mechanisms of damage to our body that are involved in living with this disease. And I've really pulled out three key ones here. There's the infections we get from our own bacteria that are already in our bodies that have colonized us. And then for the kidneys, we can also get urinary tract infections. That's that UTIs acronym. where bacteria from the outside of our bodies can travel up through the urethra, which is the tube that connects our bladder to the outside of our bodies, and then travel up from the bladder through the ureter, which is the tube that connects our bladder to our kidney on each side if we have two kidneys. So bacteria, as usual, are a constant threat for us. And I will say there's a really interesting literature out there on E. coli specifically, which are a common bacteria that's present in the genital region, and on ways to mitigate or prevent colonization of the bladder and the kidneys by E. coli. There's some cool stuff out there in the literature right now about what we can do in our individual care to make sure that we don't wind up having repeated UTIs. And I will say I dealt with UTIs all the time when I was a teenager, and I had horrible complications from them, including a lot of scarring in my bladder that I actually had to have surgery to address because it was pressing on all the nerves and it was causing me just terrible chronic pain. So understanding the mechanism there and being able to do some prevention has been really key for my well-being in ways that include my kidney health, but also go, out to sort of the whole renal and urinary system. Inflammation is like the hot topic right now in physical health in general, is how inflammation of different kinds is implicated in our health as we grow older and how it puts wear and tear on our bodies. Particularly relevant for renal disease and CF is that even if we do not have an active infection in one or both of our kidneys, we can have inflammation in what are called the interstices of our kidneys. And those are just areas in between. So not the tubules, not the glomeruli that actually move fluid through the kidneys, but the other areas of the kidney structure. It's a lot like having pleuritic inflammation in the wall of our lung. It's a very similar mechanism. It's just called something different. And then finally, obstruction itself, right? You're living with this disease and you have a lot of lung involvement. Probably at some point you've coughed up something that looks pretty gnarly. Maybe you've coughed up something that was kind of sort of a solid. It was kind of rubbery. It was a little mucus plug from one of your small airways. The same thing can happen in the kidneys. And I will tell you a funny little story about my parents and I looking into what exactly was going on with my kidneys, in part by examining some of these casts. That'll be a little bit later in the talk, but I have a funny story for you with a funny visual that I will also describe. We can also get kidney stones beyond those rubbery casts of mucus, and kidney stones can be made of a lot of different stuff. And some of the ways that our CF impacts our blood, like what our blood work looks like, what kinds of compounds are present in our blood, how much and in what ratio, that can really impact what kinds of stones we might be predisposed to. Family history can also play a huge role in this, as well as diet and other health conditions, hydration, all kinds of things. So nephrolithiasis is a term that you will see a lot in the clinical literature. If you are digging into the clinical literature, what that means is that people have stones in their kidneys. Anytime you see the word lith, L-I-T-H, that means it's a solid mass. And the procedure to break up kidney stones is called lithotripsy because of that. It's using ultrasound waves to kind of smash them into tiny pieces so they can be passed. That's where that comes from. And then finally, scarring. Same deal with the bladder. Scarring can happen in the tubules of the kidneys, just like it can, also in the small airways of our lungs. That bronchiectasis, the thickening of our small airways that so many of us who are my age have, I'm 40, that plays a huge role as well. And it can make it harder for fluid to pass through the kidney and get filtered efficiently. And then it also predisposes us to more other types of obstructions because it's easier for material to collect. So it's kind of a vicious cycle, which we're often quite used to dealing with in living with this disease. Then I've got some information about just the kinds of other issues that CF causes that can then come back to cause problems with the kidneys. Things like losing electrolytes, not just through our urine, but also through our colon. I have a lot of GI involvement with my CF. Geneticists don't know exactly what my mutations do because I'm actually the first diagnosed case of CF on record, at least in the US registry with my genetic profile. But I definitely experience a lot of GI involvement, and a lot of my day-to-day issues are worse on the GI front than they are on the lung front. And this really varies. I have a friend who has the double delta 508 genotype, sort of the stereotypical CF genotype, and has almost no lung involvement and almost entirely deals with GI issues. So each of us is a little bit different, and there are all kinds of reasons genetically why this is that would be well beyond the scope of this talk. So you got to go other talks if you want to learn about that. But it is a thing, and I have dealt with horrible wasting of electrolytes and challenges keeping my electrolyte levels up because of this. So some of the medications that I take are pharmaceutical potassium chloride supplements that help to address that. But here's the thing. You see that at the bottom where you hear me say it, progressive damage from medications for CF management can cause all kinds of issues with the kidneys. Pharmaceutical potassium chloride supplements are really hard on the kidneys. So I'm having to take a medication partly to address issues that my kidneys are already experiencing that in turn stresses my kidneys. Super fun. This is a common situation that we wind up in managing our CF. And finally, endocrine disruption, as well as exocrine disruption, which causes some of these nutritional issues listed above. There's endocrine disruption. I don't personally have CF diabetes yet. I don't know if I'll ever develop it. About 50% of our adult community, at least last data I saw, does have at least some degree of clinical diabetes related to CF. And that's because the ducts that let insulin out of your pancreas get obstructed. So you're making insulin, but it can't get out. So difficult to break down carbohydrates. And of course, diabetes has a lot of heavy impacts to the kidneys, especially if it is not fully managed. So there are a lot of people with diabetes who otherwise don't have kidney problems but develop kidney problems from diabetes. CF diabetes can do this just like any other kind of diabetes. All right. Now, some of us in the adult CF community have organ transplants. I have an organ transplantee in my family, but it's not me, it's my dad. My dad had a liver transplant for reasons totally unrelated to CF, and he and I are not genetic relatives, so there's kind of another layer of complexity there. But I'm very familiar with liver transplant as a general construct because my dad just passed his 5-year anniversary of getting a brand new liver. He's been doing very well. One of the things that I've listed out as a liver transplant complication is diabetes. Like most liver transplantees, my father has been quite open about dealing with just a little, very mild clinical diabetes from liver transplant that was not associated with any underlying health condition. This is entirely an artifact of the transplant and the medications that he takes to keep himself healthy as an organ transplantee. Other things that can be involved if you've had a transplant of any major organ, whether it's the kidney itself or another organ, there is something called allostasis, which is basically a fancy way of saying that our body has been under a lot of stress and has responded to that stress. Things that are involved in allostasis include cytokine storms. We heard this term a lot in relation to COVID-19, and it's basically where your body attacks itself. So it is a kind of like an acute autoimmunity type of situation that then damages the tissue. And autoimmunity is something that we deal with a lot in CF. And there are several of us in the CF community who have really been advocating for more research, both on the autoimmunity that's specific to issues of recurrent infection in CF itself, as well as comorbidity, co-occurrence, simultaneous occurrence between CF and primary autoimmune diseases such as lupus. Then there's also nosocomial infections, which is a fancy way of saying infections that we get in the hospital. And if we're inpatient, we have a much higher risk of getting those kinds of infections. Those are really likely if you've had a transplant, because if you have an organ transplant, you have to take medication to make sure that your body doesn't say, hey, this organ isn't mine, and then reject it. The closer an immune match you have with the organ that you received, the less immunosuppression you're going to need. And there are also different degrees of immunosuppression required for different types of transplants. Liver is the lowest, double lung is the highest. So some differences there. Then finally, hormones, definitely a topic of greater interest these days in the CF community. I don't know if anybody else here has been involved with the CF Reproductive and Sexual Health Collaborative, the CFRESH, but I've been working with them since their inception, and I actually led the development of a chapter on sex, gender, and sexuality for their research guide. But we've also got, stuff about, general hormone health and things like that. And hormones impact our kidneys, like the whole endocrine system really is involved here. And how much fluid we excrete and how efficiently our kidneys can process fluids, does depend in part on hormone levels. So, for example, often before somebody gets their menstrual period, hormone levels will change in ways that impact excretion. And then there tends to be a release of fluid once menstruation starts and a new hormonal cycle starts. So I really want people to keep in mind that, as well as the fact that both medications for CF management and medications for transplant management can be relevant for people who are living with CF and have had an organ transplant in terms of renal health. I gave some notes on what's in the scientific literature, just so that people who are interested in digging into that kind of have a place to start for key references in the literature. But I'm not going to go through these in detail because this isn't a scientific conference. So if this is an area that you are interested in, I do have 3 slides, sort of toward the middle of my deck, that go over basic science, which is like your biology, your chemistry, think stuff that's happening in a wet lab with lots of tissue samples. Then we've also got an overview of some clinical management literature that has things like how kidney disease is diagnosed in CF, how we measure different indicators of how somebody's doing with their CF kidney disease, ways to treat it, and the kinds of clinical outcomes we're seeing from treatment approaches. And then finally, I've got a slide about research based on patient experience. There are a lot of us in the CF community who are scientists ourselves and who are clinical educators ourselves, and who draw on our experiences of living with the disease. And some of this research I'm going to kind of explode for you as we go through clinical best practices that you can talk about with your clinicians or with clinical profession students we are teaching. But I've done a variety of work on this topic, so I guarantee you, if you are looking through research on kidney disease and CF and you see the last name Nowakowski, that's me. So far, a lot of the research on this topic that really engages patient experience directly from that dual perspective of patients and scientists, was written by me. There's always one of us to start, but there are other people who are working in this area as well, who have CF themselves, and especially as you get into like industry and some of the drug development efforts, as well as computational models for different types of disease outcomes and treatment pathways in CF. There are a lot of us who are working in that field. So I gave you a few examples from my own work because I really want to take you through some of the nuts and bolts of that, and nobody knows my own work better than me. And that also lets me talk to you a little bit about my own lived experiences with CF kidney disease. So, the promised funny story. So I have on the left-hand side of my slide a picture of a couple of jam jars with dainty little gingham lids. And over on the right, I have some information, some of which I touched on before, about what makes me unique as a CF patient. So I've got kidney disease, yes. I don't have an organ transplant. I have had a lot of reconstructive work done, especially in my mouth, the dental damage and periodontal gum damage from CF is an often silent issue that affects a lot of us who are in the adult community, and especially those of us who are approaching middle age and later ages. If you are sighted and you are zooming in on your screen, you can probably see that I have some pale colored stuff in the middle of my mouth, but all of that is porcelain. I don't have natural dentition really above my gum line. And I've actually had multiple surgeries to reconstruct my gums using connective tissue grafts because they were destroyed by progressive damage from infection, so much that I had exposed bone at the root of each of my teeth when I was a younger adult. And that's not something that everybody in the CF community has dealt with, but it was a big part of my experience. Some of the things that make me unique as a patient that I've mentioned before is my ancestry, and how, although I have white privilege in a social sense, I have certainly been impacted by a lot of those ethnically and racially linked disparities in both access to different kinds of treatments, as well as other factors that shape my care experience. And I was initially identified as probably having CF when I was very young. My parents knew, basically once they started changing my diapers, what was going on. They taught medical school, and they knew that certain things that they were seeing were very familiar. Chronic bronchitis and pneumonia, the sort of messy, fatty, stools, all that. And I was tentatively diagnosed with it when I was 5, but here I'm living in Florida. I'm wearing black and long sleeves in the dead of summer. I'm pretty cold nature, and I don't sweat really. The only place I really sweat is like my brow line and my armpits. Even if I'm outside, like working in my yard in the sun on a hot day, I just don't sweat very much. And I could never give enough sweat as a kid in the multiple sweat tests that were run on me for the sample to be considered valid, even though the result was concerning. But, my medical educator parents, and especially my father having a strong background in genetics and genomics as part of his scientific practice, they knew what they were seeing. This is not a subtle disease. And because I was white, doctors thought that I could have it. I have friends, including my dear colleague, Terry Wright, who founded the National Organization of African Americans with CF, who wasn't diagnosed until he was 54, even though he had a pretty standard clinical presentation of the disease. For every person who makes it that long, who never got a chance to get diagnosed because of systemic racism, there are a lot of people who died, whose stories are not being told because they never made it out of childhood, maybe not even out of the first couple of years of life. And I guarantee you that a lot of people whose stories we are not hearing because of these systemic oppressions had kidney impacts. So some of the worst outcomes we're not hearing about because people are what's called left censored from the data. People never get a chance to get into the data stream in the first place that we use to narrate what a particular health phenomenon looks like, because people are stereotyped as, well, you can't have CF, you're Black, you're brown. Well, you can. This disease doesn't discriminate. Anybody who has any type of genetically linked issues that impact the production, transport, and or residual functioning, the function on the surface of the cells of this little protein, can have the disease. But it's mostly been white people getting care for it. I think I am here talking to you today because I happen to be born with lighter skin. And that's something I think about every day that really drives my practice as a clinical educator, is encouraging that inclusive kind of thinking. And then there's the fact that each of us is unique. Each of us has a different social history. That's a way that we refer to somebody's life experiences and what's happened in their relationships. I have been married for the past 8 years and counting to someone I have a very wonderful, thriving relationship with, who really supports me as a person living with a chronic physical disease. And also, we have a shared experience of living with complex trauma. I had a very different life before I moved to Florida, and I was in an abusive relationship, and it left long shadows. And those are things that I deal with every day, and including, the outcomes physically from the allostasis, the toxic stress of living in an unsafe home, and of really having to manage some of those kinds of issues now. I've been out of that relationship for a long time, but it still affects me. And then also just medications I've taken. There have been things that a lot of us were prescribed when we were younger to help manage some of the issues that RCF causes, like with our digestive system, that it turns out can be pretty hard on the kidneys. So I'm thinking about things like ranitidine, which is an acid blocker that can actually really stress your kidneys. And I used to be on that, even though I didn't have a lot of issues with acid reflux. And I remember at the time asking my clinicians, do I really need this? I know it can be kind of hard on the kidneys. Well, I eventually got off it. But there's been a lot of those kinds of issues. And then some of these modulators also that are doing such wonders for things like respiratory health, and also restoring some exocrine function with the pancreatic enzymes getting into our intestines to help us digest our food. They can be pretty tough on the kidneys too. There's a fair bit of literature out there now about Kalydeco, which has the active ingredient ivacaftor. That's the oldest modulator that was developed for some very specific genetic mutations that cause issues with how the protein is getting through the cell membrane. That's called gating. And then also working on the surface of the cell, that residual function. Well, ivacaftor works wonders for people who benefit from it oftentimes, but it is hard on the kidneys. So that can be a trade-off, as what's most important, what's your biggest barrier with your health right now. And then there's a similar calculus with other modulators. There's Orkambi and Symdeko for the double delta folks, as well as the Trikafta triple combo therapy that addresses both the folding and the gating of the protein that supposedly might benefit about 90% of the CF community. But some folks have had a really terrible experience with adverse effects from Trikafta, even though they may have also experienced quite a few benefits for things like respiratory health. So everybody has a different reaction to each therapy. There is no one size fits all approach to treatment. That's true in general for CF, as it is for pretty much any chronic disease. And it's very true specifically for our kidney health. So why the jam jars? We're finally getting to that. Why are these jam jars on your screen? Okay. So I told you I was raised by basic scientists who worked with specimens in labs. Well, when I was a younger adult, I was in my early 20s, and I was noticing what were clearly a lot of kidney-related issues, with cloudy, foul-smelling urine, flank pain, like where your sides ache, just reduced urine excretion, edema, which is where fluid pools in different parts of your body, and especially edema in the legs that then would get somewhat better if I'd put my legs up and elevate them above my heart level. All right. So I'm like, okay, grew up at a medical school, pretty savvy consumer of health services. I had not had my CF diagnosis confirmed by genetic testing at that point. But we had known since I was like 5 years old that I probably had this disease, and I'd been cared for throughout my childhood and adolescence as if I had it. But I didn't really get much follow-up as an adult, because at the time there was not a lot of really great adult care available to begin with. And then in addition, there was kind of this chicken or the egg question of, well, is it really CF, or is it other like a primary autoimmune disease that's mimicking CF, or what? So it got a little convoluted, and the follow-up was just very inconsistent. So I was very sick as a young adult. And one of the worst sets of issues that I was dealing with was the renal stuff. And in fact, I was admitted to intensive care when I was 23 with what looked like the beginnings of end-stage renal failure. So that was not a fun night. It turned out that my kidneys were not dying, but they were very stressed. So when all this was going on, as I was out of intensive care, I was really starting to I was sort of looking at my urine and being like, some of this stuff is weird. So I'm describing some of this to my parents, and my laboratory scientist parents cheerfully say, oh, let's take a sample. So my mother who I think many people from a certain era would save jam jars as storage containers. And so my mother gets out, she doesn't have a specimen cup handy, but she has an empty jam jar that's nice and clean. Takes this jam jar out of the cabinet. It's got this dainty little gingham lid. And she's like, okay, let's get a sample. So I'm like, okay, I can take it in the bathroom, pee in the jam jar. Bring a jam. This is like a normal thing to do at home with your parents, right? You're welcome to my family. So I bring this jam jar full of urine back into the kitchen, and we look at it under the light fixture, and we're all sort of goggling at it, like. And I remember my dad saying, "What is that stuff floating in there?" There were these rubbery filaments. And they were bigger than albumin filaments. So human urine has a small amount of the same kind of stuff that makes egg white look the way it does, a little protein called albumin. That's different. These were kind of, they were kind of chunky, folks. They were these rubbery filaments that almost looked like little worms. And they looked kind of like a smaller equivalent of the rubbery kind of semi-solid mucus plugs that you can cough out of your small airways. So I was not surprised seeing it start to come through in the clinical literature as the years went by that, oh, well, yeah, if you have CF and it's really affecting your kidneys, you can have mucus casts in your kidneys just like you can in your lungs. Right? So no surprise. But as my father always liked to say, the way to become a famous scientist is to prove something that everybody already knows to be true. So we're seeing more about this now in the clinical literature. But hey, fun fact, if you too have ever taken a little sample of your urine at home and given it a look and you've wondered why is this like weird chunky stuff floating around in there? And it's kind of rubbery because we analyzed the samples, like we did some physical testing. They're not solids, they're not stones, but that's probably mucus casts. And then the little tiny white filaments, that's albumin. That's just stuff that's going to be present in human urine, although if you have more of it, like a high amount relative to your baseline, that probably means your kidneys are stressed and they're kind of chucking out more protein than they should be. All right. So let's talk a little bit about some clinical practices. I did this article in Frontiers in Medicine a few years ago, and that's one of the articles that I put on the slide about patient experience research that kind of takes people through, what have I learned from engaging the literature, from being a clinical educator, and from working with my own clinicians about how to safeguard my kidney health as a person living with CF. And as I grow older, this stuff becomes even more important. So far I'm working with all original equipment as far as major organs go, and it's not necessarily what it would be if I didn't have CF, but so far so good on not needing a transplant. But if I do need a transplant in the future, at least so far, since some of the interventions that helped to turn my lung health back around after my 20s. It looks like the most likely transplant, barring any unknown unknowns, which there always are with CF, would be that eventually I might need a kidney transplant. And this is something I'd be open to talking about. The technology is also changing. So in addition to the surgery and recovery often being a lot more efficient and having better outcomes now, there have also been some quite successful trials of alternatives to cadaver organs. So oftentimes when somebody gets an organ transplant, if you want a kidney transplant, it used to be that you had to do one of two things. Either you get a match from a person who is an organ donor who has passed away, who had a viable kidney that matches your characteristics, or one of your family members, your direct genetic relatives, is determined to be a match for you as a kidney donor, and they give you one of their kidneys. And I have had arguments with my mother over the years about, please promise me you'd take my kidney if it came to that. I'm like, okay, we don't even know if you're a match, A. B, hold on to your organs. I don't need a transplant right now. And there are probably going to be a lot of different options, available in the future that might not be available now. So let's just, hold on to your kidneys for the time being. All right. One of the things that's been done successfully a few times is using the matrix of a kidney from another animal, such as a pig usually, stripping it down to the connective tissue, which is similar to the frame of a house, and then seeding it. And I think about this in the farming context, like you are planting seeds that are going to grow. Seeding it with the person's own stem cells, which are a type of cell that basically gives instructions for how tissue will grow. Tissue grown from your own stem cells is your tissue immunologically. Your body recognizes it as its own, so no need for immunosuppression. This is a big part of the future of kidney transplant, is growing people new organs that match their body already. So then all that anti-rejection medication, that goes out the window. Pretty cool. There are also implantable mechanical kidneys. So, there's hemodialysis, where you go to a dialysis center and you get hooked up to a big machine that pulls your blood through it, and you sit there for a few hours, you read a book or whatever, and you do that a couple times a week and you go home. That's one way to clean your blood if your kidneys aren't working. Another way is peritoneal dialysis, where you yourself manage a setup that draws fluid through your abdominal cavity. Peritoneal is a fancy way of saying that big cavity in the center of your abdomen where all your organs go, that basically filters your blood the same way a drain field on a septic tank would filter the effluent, the liquid that's coming out of it into the ground. Then there's home hemodialysis, where you have a little machine that kind of looks like a big cassette deck. So I may be showing my age here. I don't know how many people even grew up with a cassette deck, but I did. Born in 1983, used to tape songs off the radio. But big cassette deck that goes kind of on a night table. You have lines that go, into your arm, and it draws your blood in, cycles it through, puts it back in your body, and you hook up to this at night while you're sleeping, and you wake up with clean blood. So different types of dialysis have advantages and disadvantages. Each of them, puts a burden on the body in and of itself, but you got to be able to clean your blood if you want to live. Well, now there are also additional options for basically implantable devices that can filter blood. So this is not widespread technology yet, but that's another branch of research on, how do you replace the function of a person's original kidneys if it's really diminished. And I know people with CF who've had kidney transplants, some of whom have had them because of direct impacts from their CF that damaged their kidneys, and some of whom have had them because of having another organ transplant and then needing a kidney transplant because the double lung transplant anti-rejection meds damaged their kidneys so badly that in time they needed a kidney transplant. So lots of different experiences. But let me take you through some of the things that I've talked about with my clinicians to help me stay healthy with my CF kidney disease. So sexual activity, not everybody has sex, not everybody wants to have sex, but if you are sexually active, your sexual activity and the infection control that you practice with your sexual activity can make a big difference in your renal and urinary health. This is often a topic that clinicians don't ask their patients about because they think it's awkward. I would encourage any of you who are sexually active to empower yourselves as much as you can, that you have a right to talk to your clinicians about this beyond any fields of specialty that are sexual and reproductive health related. Our sexual health matters for a lot more than just our genitals and our reproductive organs. All right, edema, this is a big one. So although the issues of like weight maintenance have evolved a lot in our community, especially as some of these new modulator drugs have come out and there have been improvements in other types of therapies that we take, maintaining our weight is still a big challenge for a lot of us. And then just family history matters as well. My mom's family are all really skinny with fast metabolisms. And from what I know about my biological father's family, it's similar. So I probably wasn't going to be real strapping even without CF, but I have to eat like 4,000 calories a day just to maintain like 85 pounds body weight. And I'm 5'4", so I'm not working with a lot there. So it's often been missed when I've had edema because people look at me and they're like, "Oh, you're so slim," right? Okay, but that doesn't mean that I can't have swelling relative to baseline. Anyone can have edema. And I was having situations where I was telling a clinician, like, I have edema, and giving them like a very thorough clinical description of it. And you could see that the skin on my legs was stretched and shiny. And I would say, like when I wake up in the morning, when I've had my legs up at night, I can see my shin bones at the fronts of my calves. But by the end of the day, I can't. And the skin is stretched and shiny and it feels hot and my legs feel heavy. And, I can see the visible difference. If there's no compression on my calf, I can see a visible difference. And sometimes people still didn't believe me because I was small. Not all edema is lymphedema, where somebody's limb swells up enormously to multiple times its original size. And even lymphedema is progressive. And if it's caught early, usually the prognosis, what the person is able to experience over time is going to be much better. So encourage your clinicians to really pay attention to all the different things that you know about your own body. Nobody knows your body better than you. And that's as true for indicators of your kidney health as it is for anything else. Talking about transplant early and really having that be a continuous culture of discussion in your care is important. A lot of us in the community have dealt with a lot of fatalism, surrounding the idea of receiving an organ transplant if we wind up needing one. There's this idea that many of us have struggled with, and even my dad struggled with this because a lot of the men in his family had died young from an underlying chronic disease that he also has. It's not CF, but it's something. It's a vascular condition. And, this can really set in. And this can really set in even if day to day we're very assiduous, we're very, very diligent about managing our health and really trying to stay on top of things. It can be really defeating to live with a progressive disease, right? You can slow it down to a drip, but it is still progressive. And I still think about that. And when you're doing really badly and you're suffering a lot, your quality of life is low, maybe you are not so keen to stay on the bus. What I wound up realizing, this is something that my parents always told me, but I wound up realizing it in a very visceral way when my father went through his transplant. It's important to actually let ourselves get the information and make decisions about what we want for our health and what we want for our life. And it broke my heart to hear my dad say that he felt that he would be a waste of an organ. And the whole time that this was going on, I couldn't be with him physically because the hospital environment was dangerous to me. And my lung bacteria that I can't get rid of were dangerous to him because he was so immunocompromised from when he had end-stage cirrhosis of the liver, absent any history whatsoever of really alcohol use, let alone abuse. No HIV/AIDS, no hepatitis, no cancer. 16 different liver pathologists at Mayo couldn't figure out why his body killed his liver, but it did. And I remember actually sending him one of the research publications that I wrote, the original parts piece that talks about the experience of living and aging with CF kidney disease and having to reckon with the fact that I might need a transplant someday. And I said, years ago, you and Mom, you encouraged me to at least think it through and really let myself get the information to talk to other people with CF who've been through a kidney transplant and not dismiss the idea out of hand that this would be worth doing. And I said, I'm gonna give you the same ask. And if you decide you don't want to get evaluated that you don't want to go on the list and that you just want to live out the rest of your life with your original liver, I will respect that, absolutely. You have a right to that autonomy. But I'm begging you, and I did use the word begging, please let yourself really consider it. Well, my mom calls me the following week to let me know that she's taking him to Mayo Clinic for a transplant evaluation. So CF came in handy. In that moment, even though I could not be there with him physically or contribute physically to his care, I was able to do something that mattered. And so I've been grateful for what my CF has exposed me to, because it helped me keep my dad in the world. And he had an awesome experience with his liver transplant. He drove everybody nuts while he was recovering because he was bored out of his mind before his last drain came out. 5.5 years later, no rejection or anything, just a little bit of post-liver transplant diabetes. Nutrition, that's a big one for us, and especially for me, it's one of my major challenges. It's tough because you've got all these competing needs to manage. How much protein? If you don't get enough, you have issues. If you get too much, you have issues. Sugars, all kinds of things. And that's even without diabetes. And for every new issue you experience, it's that much more difficult to manage the others. So keeping abreast of our nutrition as it relates to our renal health is major. Electrolytes. The electrolyte wasting is a huge issue for me, and I've had a lot of heart damage because of it too. I have a chronic condition now called long QT syndrome, where the waves, like the spiky parts in your heartbeat, get pulled so far apart that your heart can actually stop for a moment and then restart. This is called long QT syndrome. Q wave and the T wave get too far apart, the heart's going to skip and stop completely for a split second. I found this out in a not so great way that I don't think I have time to go into, but it's a little spooky. Certain antibiotics can make that worse. One of the great ironies that I live with on a daily basis is, well, I have this population of Mycobacterium avium complex, the MAC, that almost everybody with CF whom I know who lives in Florida deals with. I can't get rid of my MAC at all, because the antibiotic that's most effective in treating MAC, which is azithromycin, will stop my heart. That is how I found out in not such a good way that I have long QT. Hit the deck in the parking lot of a Target. Oh, I tell you, I've never seen Target employees looking so spooked. They looked like they'd seen a ghost when I just popped up and reanimated suddenly. It was wild. But yeah, no azithromycin for Zan. But all these things kind of run together. All right. Specimen cups, peeing in a jam jar makes for a good story, but it's not ideal. So these days I keep sterile specimen cups on hand at home that my clinicians give me, so I can take samples of my pee and my poop and turn them into labs anytime that they need to look at it. One of the funniest experience that I ever had was going to a lab and dropping off a fecal sample and having the nurse look at it and be like, CF, right? And I'm like, how did you know that? Nurse had a nephew who had CF. So we talked a little bit. It's very unambiguous if you know what to look for with our poop samples. But the sample collection, right? Like there's procedures. And one of the frustrations that I've had in my care is like, well, don't have me take the pee sample, but not give me clear instructions on like how to store it, how much time it's valid for before I take it to the lab or anything like that. I don't want to waste pee collection. It's not that easy to pee into a small cup. So respect for time is important too. Blood glucose, diabetes, right? That's a pretty obvious one. How much water am I drinking? Hydration. Am I overstressing my kidneys by over consuming water because I'm thirsty all the time because bacteria are having a big old party in my mouth? Lots of issues there that can be mitigated in a number of different ways, including saliva stimulators like pilocarpine, which also now is used for arm swabs for sweat tests for CF. And in fact, I had my sweat test repeated as an adult for research purposes. Guess what? Pilocarpine, electrical current through the skin, still not enough sweat for a valid sample. Some of us can't give a valid sweat sample. That's why it's important to have multiple pathways of diagnosing the disease and monitoring our health. Ask me about my comfort and whether I'm in pain. Pain is a vital sign recognized by the Joint Commission that accredits hospitals in the US for a reason. It's a sentinel for a lot of things that can be going on with us, and our kidneys are no exception. We tend to know our own bodies well, and if something's weird, probably we've got a sense of it and are going to be able to give some description of it. And then finally, can't stress this enough, if you're a nephrologist, coordinate my care with my CF specialists. That really saves a lot of time, and it also means that things don't fall through the cracks when the CF clinician knows something's up or has an ability to interpret something in a meaningful way based on their knowledge of my history and what we might be able to do about it. So if your specialist, if you're seeing a kidney health specialist and your specialist is not coordinating with your CF team, that burden shouldn't fall on you. You can give them a records release authorization under HIPAA that they can do certain more in-depth activities in communicating with each other to coordinate your care. This is a legally permissible use of patient data, and you have a right to engage it. Little bit of a look ahead. We've got lots of research going on right now about protein modulators, the kinds of impacts they can make on the kidneys, both for good and for ill, and oftentimes it's a combination of the two. And really getting a handle on that and how additional stress to the kidneys can accelerate the progression of CF kidney disease. That's a big one. We talked a little bit already about some of those options for care and functioning supplementation like dialysis in end-stage renal disease. And then finally, we got to some alternatives on traditional organ transplant. So I already covered what I wanted to cover on this slide, but I kind of put it here as a reminder of where we're going. Thank you all. You were a wonderful audience. I hope you really enjoy the rest of the retreat.